Good morning and welcome to today's webcast. What do site-neutral payments mean to your off-campus facility? We have three great speakers joining us for today's presentation: Larry Vernaglia and Jennifer Walsh of Foley and Lardner, and Cheryl Storey of Moss Adams. Larry is a partner and healthcare lawyer with Foley and Lardner and serves as chair of the firm's healthcare industry team, named Health Law Firm of the Year for 3 of the past 4 years on the U.S. News Best Lawyers, Best Law Firms list. Mr. Vernaglia represents hospitals, health systems, and academic medical centers, and a variety of other healthcare providers. Jennifer is a public affairs director with Foley and Lardner. She has extensive experience in government affairs, including a lengthy career as a senior staffer in the U.S. Congress and the California Legislature, and as a vice president for federal government affairs at a top
and thanks for joining us.
Healthcare company.
Moss Adams is pleased to present another in our ongoing series of continuing professional education webcasts.
House of Representatives and the
Our presentation will start in a few moments.
She is a member of the firm's
Before
government
we begin,
and public policy
here are a few things to keep in mind.
Cheryl has built her experience in the healthcare field
You can customize how you both view our
years.
presentation
She
and interact with the presenter.
Medicare and Medicaid reimbursement
For better viewing,
and related
close all other applications and turn up your speaker
Cheryl
volume.
has worked with healthcare providers
You can also
on
adjust
medical
window size and
education
placement.
programs, compliance with
At the bottom of
CMS's
your screen, you'll see a series of icons, each relating to a different aspect of our session.
And certification
For
and
example,
licensure of
you can
the
click the
provider-based
file folder
department
icon
in
to
conjunction
download
with
the group
applicable
attendance
State
sheet
Department.
and a PDF copy
Larry,
of today's
I will now
slides.
turn the line over to you to begin today's presentation.
You can ask our presenter questions during the webcast
Thanks, Emily,
by clicking
and
Q&A
let me thank my
in
good
the bottom
friends at Moss
left-hand
Adams
portion of
for
the
helping
icon
to put
bar
together
and typing
this
in your
interesting
question.
program. In particular,
We'll do our best to
my
answer
friend
all
Cheryl
questions
Storey,
during the
who's
presentation
going to be
or follow up via
today
email.
with me and Jennifer on this important topic: what does site-neutral payments
We'll ask polling questions
mean to
throughout
you?
today's presentation.
And what we have
Per the National
today
Association
is
of State
one
Boards
of
of
a series of
Accountancy
interesting
Webcasts
issues that are
CPE
going on
standards.
for hospitals
CPE
and their
credit will
outpatient
be awarded
departments
based on your
just
participation
over the past
in these
9
polls.
months. If you
To
think
respond
about
to a
it,
poll,
just
click the
since
button
the
next to your
spring,
answer.
we've had a dramatic
If you're attending this webcast in
level
a group,
of increased attention
you must
to the
complete our
so-called
attendance sheet to
shared
receive
space
CPE
prohibition
credit.
for provider-based
Please have all group members sign the
departments
sheet,
for hospitals.
and please remit only
We've
one
seen
sheet
new
per
stark
group.
exceptions that
Also
implicate
note,
these
today's
facilities,
session will offer
such
you
as
one
the new
CPE
timeshare
credit.
exception.
To receive
And we
credit,
have today's
you must meet the
topic,
requirements
which is the
as specified
impact
by the
of
National
the
Association of State Boards of Accountancy.
Bipartisan
You
Budget
must
Act
attend
of
at least 50
2015,
minutes
Section
of the session
603,
and respond to at
which is
least
going to be
75%
our topic
of the polling
du
questions.
jour. And we
CPE
hope that
credit can
over
be
the
awarded
next
only to
hour
participants
or so,
registered
we
as
will be able to
themselves,
cover the legal
and is
issues,
not
the
available
public
to
policy, as
participants
well as
who
the
view
finance
on-demand
and
version.
operations issues that arise
We'll
from
track
this
your progress
short,
and alert you
but
when you've earned
in
CPE
our view,
credit.
very
You
dramatic
can then
and
click the certificate
far-reaching
icon to
statute.
open a PDF file you
So
can
let me
save to your
jump
computer.
right in to make sure that we're all on the same page about what the
As a reminder,
Congress
the presentation
did
you're about to
at
see
the end
is not
of last
legal,
year.
investment, or accounting
And
advice.
here's the short of it.
We
that,
encourage you to seek the
as
counsel of a
of
professional
January
service
1st,
provider to
2017,
apply this content to your specific
an
circumstances.
off-campus
We're now
outpatient
ready to
department of
begin.
a provider
Thank you.
can't bill under the outpatient prospective payment system for Medicare unless either it's grandfathered or it qualifies as a dedicated emergency department, an EMTALA term we'll spend some time on in a moment. After this date, unless you're grandfathered, and you don't meet the DED carve-out, you're going to need to find another way to bill other than OPPS. And we're not exactly sure what they will be, likely the Medicare physician fee schedule, but maybe some others such as ambulatory surgery centers or rehab centers. There may be others as well, and we're going to have to wait for what CMS chooses to do to figure that out. But this site neutrality, at least for new facilities, is exactly what MedPAC, the Office of the Inspector General, a number of payers have wanted for years. In fact, many people said it didn't go far enough because it's allowing for grandfathering, which we're going to talk about in a moment. This law was only passed in December, so what we have is a statute only a couple of pages long. There is no regulation or really any other meaningful guidance. People like Cheryl and Jen and I have been trying to read tea leaves to figure out what the impact is going to be on new facilities as well as potentially some existing facilities. And we are doing our best, but right now we're going to have no guidance from CMS, at least until June or July when the outpatient prospective payment system rule comes out, where we believe that they will issue their first interpretations and guidance. So let's talk a little about why this Section 603 was passed. Well, it's purely a revenue play on behalf of Congress. It was designed, that plus the extension of sequestration payments were designed to lift the debt ceiling, increase some domestic spendings, and avoid increasing Medicare Part B premiums. How much is going to be saved? Well, the CBO scored this at around $9.3 billion over 10 years. And that's the savings they were hoping to achieve. There was a flurry of activity at the end of the year with hopes of making some modifications to the statute. And right now, while there may be some additional legislation coming that we'll let Jennifer talk about towards the end of our time together, this is the law as it stands today. Note that CMS states that, or says that, Section 603 is not effective until January 1, 2017, and that it won't change anything until then, and I think that's true. But the grandfathering provisions we'll speak about do look back in time to before the passage of the statute, and it is conceivable that actions that providers take in the coming year could impact the compliance and grandfathered status of their existing facilities. So with that background, Emily, let's launch into some of our first polling question before we start digging in. Emily?
All right. So our first polling question is, are you from a hospital or health system, a physician office, other clinical practice, or non-clinical? I'll give everyone a few moments to respond. To participate in the polls, just click the Submit button after you select an answer. And I'll give you all a few more moments. And we'll take a look at the results. Larry, back to you.
All right.
Cheryl, those numbers don't surprise me too much because this is an issue that's dramatically important to hospitals, particularly as they try to sort out what some of these terms in this little thin statute mean. One of the most critical of these is in the definitions. Do you want to walk us through some of the definitions, particularly the on-campus one?
Sure, Larry. So what we're going to do is go through, first of all, what's on campus. And it's going to be your buildings or structures within 250 yards from the main building. And there's been a lot of question as to what 250 yards means. And we're finding that not all the states are consistent. So we're hoping CMS will improve the consistency in the way states evaluate the 250 yards. But we do have some definitions from some states that if it's more than 250 yards, it's still considered on campus if you have a connected sky bridge or something to connect the one building to the other. Before we received this, we once had one of the states tell us that it had to be 250 yards from the ED entrance, which would really impact the number of buildings considered on campus. So it's kind of a question as to how many people are going to start building sky bridges. So it's really important to check with your particular state. And another thing to consider is not every state licenses ambulatory care facilities as part of the hospital. I know that Idaho and Montana don't necessarily license or survey those types of facilities. So then next, what is off-campus? Well, it's the opposite. Off-campus, you're not on the main campus. You're more than 250 yards from the main building, a remote location of the hospital. As Larry had said, it's awkward language in the bill, and so we're waiting for CMS interpretation. And then, of course, there's the regional office, CMS, that you might want to get in touch with and see what their interpretation is going to be. You also, if you want to be an off-campus outpatient hospital department, you really do need to be part of the hospital, licensed as part of the hospital in those states where you can license. And CMS does not allow off-campus departments to be joint ventures to the main hospital. a joint venture can be inside the main campus, but it can't be an off-campus facility. At this time, Section 603 applies effective 1/1/2017 for any new department opened on or after November 2nd, 2015. Apparently, the proposed inpatient PPS rules might have some more definitive language and interpretation by CMS when it gets published in April. Note that RHCs and FQHCs, except for certain FQHCs lookalikes, are not off-campus departments. They're licensed under a separate provision. This also does not impact satellite facilities, such as if you have an off-campus rehab inpatient department or even another inpatient DRG facility off-campus from the main building. And then the next slide, dedicated emergency room. There is a specific Code of Federal Regulation that explains what the dedicated emergency room is, and these are the ones that are not going to be subject to the Section 603 provisions. So make sure you're licensed as an emergency room or department. You're held out to the public by the names, signs, advertising, and you provide care for emergency medical conditions on an urgent basis without a previously scheduled appointment. It's interesting that part of the Code of Federal Regulation provision indicates that at least 1/3 of all of its outpatient visits are for emergency conditions, and then apparently 2/3 could be, up to 2/3 of the visits could be scheduled visits without affecting your dedicated emergency room conditions. So there is questions, is what's going to happen to non-emergency room visits in an off-campus dedicated emergency room? We are going to be waiting for CMS interpretation on that. Larry, did you want to add anything more on the emergency room?
Sure. I'm happy to. And there's a couple of thoughts that I have about this. The first one is that when this regulation was originally promulgated about the definition of a DED, it was designed to drag in facilities that providers probably didn't want to be subject to the EMTALA obligations. And so it was written kind of broadly to catch more sites. Now that Congress has incorporated this by reference, which is kind of interesting from a statutory perspective. You don't see Congress incorporating a regulatory process very often. But that's a digression, I suppose. What we see is a broad-scoped DED definition now being useful to us in the provider community because a new facility which meets the DED definition, even if it was billing on or after November 2nd, 2015, would be able to be a OPPS billing site. Now, to your question, Cheryl, I think you're asking one of the several $60,000 questions here, which is what happens to the non-emergency services at the DED? And while you're right, we're going to have to wait for CMS. My bet is that they acknowledge that everything within that department is eligible for billing under OPPS. Otherwise, it'll be just a nightmare to implement because you'd have to, after the bill was out, after the patient had already gotten registered as an outpatient, after they'd been given their notice of beneficiary coinsurance liability, assuming EMTALA lets you do that, some would then have to be billed like a freestanding and some would have to be billed like a hospital. I think it would be a complete chaos. So my hunch is that CMS will do the right thing and acknowledge that once this site is a DED, that it's all in for OPPS. I don't know if you agree with me, Cheryl.
Oh, I think that sounds good. That's what we're hopeful for. So then next to the polling question number 2, Emily.
All right. Our second polling question is, has your hospital or health system opened or is planning to open off-campus provider-based departments after November 2nd, 2015? And your options are yes, no, I don't know, or my organization is not a hospital or health system. Give everyone a few moments. And as a reminder, if you would like to earn CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. I'll give it a few more seconds. And we'll take a look at the results.
Well, again, Larry, this corresponds to the percentage of participants that are in health systems, but 50.7% of you are planning to open an off-campus department after November 2nd, 2015. So, of course, Section 603 is going to have significant impacts for your organization. 25% are don't know, and go ahead. Yeah.
Well, no, I didn't mean to cut you off, Cheryl, but I think that this is a really important and big number. And Jennifer, you might have some thoughts on this as well. We note that during the negotiations of the discussion around the bill, we were looking for folks who were willing to wave their hand and say, "Yeah, we're building. We want to build one, and we're worried that we won't be grandfathered." And not a lot of hospitals raised their hand. Now, in our sample, which is obviously a well-informed group, we have half who are saying, yeah, probably, and then 25 who say they don't know. What do you think, Jennifer?
Yeah, I agree, Larry. I think that's very significant, and I think we'll get into this in a couple of slides a little bit more into some detail, but, I mean, there is a bit of a desire, more than a bit of a desire, there's a desire within some in Congress to go back and look at this a little bit more carefully and consider whether some additional grandfathering under certain circumstances is required. So, again, we'll talk about that in a few slides, but I do think that it's significant, and I'm not going to pretend it won't be a heavy lift, but I do think that it's possible.
Looks like pretty important data to me.
You bet. I think it turns back to you, Larry.
Sure. One of the most important issues that Cheryl and I have been kicking around today and earlier is the issue of grandfathering, how to get it and how to keep it. Those are, I think, the first one might be easier than the latter one, but we'll try to help work that through over the next several months. So maybe the easier one is, how do you get grandfathered if you're an off-campus outpatient department of a provider? Now, remember, this law only applies to the off-campus departments. It does not apply to on-campus departments. And the way the statute reads, the off-campus department of the provider will be grandfathered if that department was billing under OPPS for covered outpatient department services furnished on or after the date of enactment of this paragraph. And that was an awkward phrasing for me as well when I read it, but I think that probably the better reading of it is that the date of enactment was November 2nd, 2015. Some folks are potentially looking for a somewhat later date, like January 1st, 2017, but that may be a bit of a stretch. We'll see if CMS has any flexibility on that. But the point here is that the date you were billing is what matters. And what that will also mean is that if you had a licensed facility, maybe a facility that had even attested to provider-based status, if it hadn't dropped claims on their UB under OPPS, it may not be eligible for grandfathering. Fascinating questions from my perspective also relate to what might happen after a off-campus outpatient department of a provider had been treated as provider-based, maybe on the cost report, maybe licensed, and had dropped some bills. But if there were any changes to it, or if they had a break in the action regarding their billing, would CMS be taking any action about that? We're not sure yet, but we know that Congress is anticipating that CMS is going to collect information from providers to help implement this new law. And what information CMS is going to collect remains a bit of an open question. One thing we do know, and we can talk about that in a minute, is that you won't be able to appeal it if you don't like their information requests. We do have some other thoughts that we've been thinking about in the context of thinking about grandfathering. One is whether or not Section 603 is self-implementing or whether regulations are required. I noticed that at Tuesday's Open Door Forum, CMS specifically said that the statute was not effective today and won't be effective until January 1, 2017. So that's a potential interpretation of what they're saying. Again, we're reading tea leaves, Cheryl and me. But it's more likely that they were talking about the billing prohibition or the ban on OPPS billing for new off-campus outpatient departments of a provider. We do know that it'll be challenging for CMS to know who's grandfathered and who's not. I don't think that they have any central database for this. Not every outpatient department of a provider on campus or off campus has gone through the CMS provider-based attestation process, because that process is voluntary and it has been for 13 years. So I sincerely doubt that they would rely on that as a standard for what's grandfathered and what's not. And finally, I'm sure that all of you are now aware that there are new modifiers that are out there for hospital and physician claims to track off-campus outpatient departments of providers, or at least of hospitals, and that have been in place for the last year. But again, when they were voluntary in the past, that may not be, therefore, a good measure for who's grandfathered and who's not. I am curious, Cheryl, if you have given any thought to how they might use the modifiers to think about grandfathering, or do you sort of think of it like me, that was the first step that was meant to be used in tracking site neutrality for a more thoughtful public discussion about how to deal with it?
Larry, that's a good question, because I've been considering these modifiers, and just for iteration, it's called POS 22 is now the modifier to be used for on-campus facilities, and POS 19 is to be used for off-campus facilities. But what's interesting about it is when you use those modifiers, Larry, the hospital is only billing the physician component on the 1500 claim form. So I'm interested if CMS is going to default to site-neutral payments for these off-campus clinics to say the physician fee schedule. Are they going to set up a new modifier so the hospital bills both the facility and the physician component for the off-campus department on the CMS 1500 claim form? Because that would default to the physician fee schedule amount for the total payment rather than just the physician component only.
Well, that's only if the hospital has the right to reassignment of those claims, I suppose. Because in a lot of situations, you have physicians for whom the hospital has no right to bill.
You can see that there's a lot of questions around this that we're going to be waiting for interpretation. But I'll turn it back to you, Larry.
Well, let's talk about why people are looking at provider-based at all. There are any number of reasons why providers have thought it was advantageous to have a hospital department on campus or off campus be provider-based or not. And the options that are now available are obviously more limited. But let's ask a polling question, Emily, about why hospitals and other organizations have looked to provider-based status for their off-campus departments. Emily, would you read our next polling question, please?
Yes, absolutely. So our third polling question for today is, if your organization has off-campus provider-based departments, what is the primary reason for conversion to provider-based? And your options are increased reimbursement from Medicare or other payers, 340B drug discounts, organizational structure, patient flow, clinical integration, all of the above, none of the above, or not applicable. I'll give everyone a few moments. And for those of you that would like a copy of today's slide deck, you could download them from the folder that says Slide Deck and Handouts at the bottom of your screen. We will also be providing the slides via email after today's webcast. And let's see what we've got. Larry, back to you.
Lots of different variations in in the purposes here. And I think that for a number of organizations, they simply have always been provider-based because that's the way the Medicare program told hospitals to treat their off-campus outpatient departments. And so many of these things are simply of historic nature, though on a going forward basis, certainly a lot of providers are looking at that 340B as a significant benefit for patients and the community. And I think that one of the worries that a number of our clients have, Cheryl, is the potential impact on 340B reimbursement. I think we might have an opportunity to chat about that over the next few slides, you think?
Oh, yes, absolutely. That's one of the reasons that you or the hospitals want to still consider converting off-campus facilities to provider-based status for the 340B.
You know, it's interesting, Cheryl. In the 90s, the OIG took a few pot shots at the whole notion of the conversion of a off-campus department that was principally around physician services, and issued a report or two with their views that it was really a bad idea, and that, like MedPAC, OIG would later say, OIG said, no, these things should be treated as physician organizations. And they told CMS, or I think it was then HCFA, to stop awarding provider-based status in this way. And HCFA had an interesting response. I don't know if you remember it, Cheryl. Their response was really that, no, we don't agree with you because this is the way you demonstrate the integration of a department into a hospital. And I think that HCFA at the time recognized that there were significant advantages in terms of integration, medical records, quality, and all the benefits that the conditions of participation bring to a site, some of which are reflected here in that red bar. But I think that they're sort of underpinning a lot of this discussion, and that now it's easy to sort of forget that they're there. But if integrated healthcare systems are part of the future of health reform, this Section 603 kind of shoots a hole in it, wouldn't you say?
Oh, definitely agree. And I know that provider-based. Go ahead.
No, please. No, finish.
I was just going to say that provider-based started becoming more popular around the mid-90s, as I recall, Larry, and most of the time the conversion was done for the increased reimbursement for Medicare and other payers. And now most of our clients are considering conversion to provider-based for the 340B drug discount.
I think that's right.
And that's becoming, it's becoming an impetus. Mm-hmm.
Well, one of the other reasons is that the commercial payers haven't been as respectful of provider-based status as Medicare and Medicaid have. So it did sort of lead to some odd differences. But let's say we don't like what CMS does to us, or the MACs do to us as they roll out and implement Section 603. Another aspect of the statute is that Congress explicitly stripped hospitals of their right to administrative or judicial review for a number of these really critical issues in how CMS is going to roll out the statute. So it specifically excludes the right to get administrative or judicial review for those services that are going to be excluded from OPPS, how the other payment systems might plug in, should a provider-based department not be grandfathered, determining which off-campus departments are subject to the ban, who's grandfathered and who's not, as well as that information request I mentioned a little bit ago. Now, presumably, they didn't mean to disrupt the opportunity to have an ALJ appeal as to whether the department complies with the provider-based rules generally, the rules at 413.65 of the Code of Federal Regulations. But this means to me that providers have to be even more scrupulous with managing their compliance at those sites to manage to hang on to that appeal right should the regional office or the state survey agencies or someone else take a swing at it. We've got a few sort of almost, might want to call them considerations or final thoughts that I think are worth remembering as you think about how to describe this situation to your management team or to the C-suite, because they're inevitably going to want to report on it, is there's a few that we wanted to share with you. The first one is that, remember, CMS is telling you this statute is not effective until January 1st, 2017. So what that means, and this is my reading as well, that all off-campus outpatient departments of providers, so long as they meet the existing regulations and at the provider-based rules, they can continue to bill under OPPS until January 1, 2017. And that applies to even new facilities that are not grandfathered. I think that now is a good year if you are among those 50% of respondents on this call today who are looking to open a new facility, as you're doing your budgeting and planning, to try to figure out what other kind of freestanding payment category your services can meet. And if they don't meet those other categories, you may not be able to put them into that off-campus department. You may either need to put it into an existing department or have a new department that meets one of the other requirements, like is either a DED or potentially is adjacent to a remote location of a hospital. I'm not sure if we mentioned that as we went through earlier, Cheryl, but it's one thing that we probably should chat about before we close today, because that's another opportunity. Third point that we wanted to mention, and this shouldn't be news to you, is that if you are a dedicated emergency department, a DED, you better be ready to comply with EMTALA. That's always been true. Nothing new in the statute about that. But if you're planning and you say, well, let's just turn this thing into a DED, we'll slap an urgent care sign on the front, you better be ready to do all the things that are required to be a DED for purposes of HHS compliance. And I think that to Cheryl's earlier question, which we admit is unknown, the answer at least, there is a possibility that CMS will be restrictive at the DED sites about which services could be billed as under OPPS and which ones can't. The answer is we simply don't know right now. In fact, I think, Cheryl, a lot of the questions that are perfectly good questions, the answer is going to be an unsatisfying, we don't know right now. So I hope everyone will forgive us when the question and answer session starts if we end up saying that more times than they want to hear. I do think, though, that some of the other questions about the risks that might arise from the changes under 603 are legitimate questions to be asking now. They are things that your hospital associations, I know a number that we're working with, are raising to CMS, and I and others will be speaking with CMS about these issues. And we're trying to read the tea leaves about where CMS is going. I was happy at the open door call on Tuesday when David Wright described Section 603, and I'm a lawyer, I listened to words real carefully, and the words he used to describe the impact of it was that they would pay new off-campus outpatient departments and providers at different rates than grandfathered off-campus outpatient departments of a provider. And if they were thinking about reading the statute more expansively, they may well have hedged a little bit in how they described the impact of the statute. So I was pleased by the way it was introduced on the call. I would say that for the non-grandfathered or new off-campus outpatient departments of a provider, there are a few other things that are really critical. And Cheryl, you mentioned a minute ago the impact on 340B. Did you want to chat about some of those other impacts and issues?
Oh, you bet. Let's talk about why you still want to do it if you're not grandfathered, which we've already alluded to earlier in the presentation. 340B, and then there is the 3-day DRG payment window. Larry and I had done a joint presentation on this a few years ago, because any clinics owned by the hospital, even if they were freestanding, services need to be bundled on the inpatient claim, and it's just better for reimbursement if those freestanding clinics were provider-based for a reimbursement service. So one of the things we want to know is what's going to happen at the state level. Will Medicaid payment system follow CMS? In some states, Medicaid pays provider-based clinics more than they do freestanding clinics. I know in Arizona they do split billing, but the payment rate is exactly the same as the freestanding amount, so there's no benefit there. And one of the questions I have is, will the states continue to license off-site locations as provider-based? We really hope and we want the states to continue to treat and license off-campus departments as part of the hospital for the above reasons, 340B and 3-day DRG payment window, and we do not want the payment system to affect licensure. So we've got to wait for CMS and see if there's going to be a common definition of what constitutes on-campus and off-campus in all states. We'd hope for some consistency among all the regions. And further, it's important regarding the cost report treatment, because if you're going to be a 340B clinic, even if you're not grandfathered and you're going to be subject to the site-neutral payments, those off-campus departments will need to be reported as a provider-based department in your cost report, meaning what we call above the line or as an ancillary department, because we know HRSA looks to see where those clinics are reported in the cost report to determine if you're 340B eligible or not. So that's an important distinction for the non-grandfathered clinics. And another thing is if you do have the new departments, note that you're required to notify CMS of any changes via the 855 form within 30 days of, say, opening a new department. And I was perusing the 855 form, and they require a listing of all on and off-campus departments by address. So that might be one way CMS could be looking at what's grandfathered, not grandfathered, but there's no database in the country to easily access that information, I believe. So next, this one slide, we've got some other questions that have come up. And as Larry said, some of the answers are we don't know yet. So if a new department's moved into a grandfathered off-campus department, will that new department be grandfathered? Well, we're not sure, but the possibility is no, since provider base is specific to departments in off-site locations, not entire buildings. In fact, you can have an off-campus building and one half of it could be a freestanding clinic, and you might have a cardiac cath lab hospital-based in another section of the building. And then the other thing that has been asked is what happens if your building's torn down and you build a new one? Again, there's no clear direction at this time. It's very interesting. So with that, I am now going to turn the presentation over to Jennifer Walsh, who will discuss the political climate we're under at this time. Jennifer?
Thank you, Cheryl. So as Larry described at the top of the call, this policy was wrapped into a large budget bill that was put together rather hastily over a pretty short period of time without a lot of public scrutiny. That said, this proposal was something that MedPAC had recommended and it had been in the president's budget for a number of years. So it was used as a pay-for. Congress is always looking for pay-fors for any spending that it needs to offset, and that is definitely going to continue into 2016 and beyond. I think there was a recognition that there was a lot of confusion in the way this policy was drafted, and ultimately is going to lead to some confusion and implementation challenges. So in the final weeks of 2015, Congress did attempt to expand upon the grandfathering language, primarily by looking at giving some more discretion to the Secretary of HHS and suggesting some additional criteria under which she should consider additional grandfathering. That was considered. It did not make it into the last bill that left the station at the end of 2015 in Congress, but it is something that lawmakers are going to continue looking at in 2016. That's the good news. The bad news is that it's going to be any changes to this policy, for better or worse, are going to be probably wrapped up into a broader package of Medicare reform or so-called hospital reform bills. There have been several introduced in Congress in the last number of months, and there's a real commitment from some key leadership, including the House Speaker and a couple key committee chairmen, to look at all of these issues. So I think the point I'd like to make today is that now's the time for aggressive advocacy, not just before Congress, but before CMS as well, as they're moving into the implementation phase of this. There is a lot of confusion, which in my mind creates a lot of opportunity. I definitely think that there's a lack of understanding about what the real effect of this policy is going to be on consumers and patients. And so I think, I look at it as an opportunity, but sort of sitting back and watching this all unfold could be more detrimental than the policy appears to be at this point in time. And I think we're going to move on to our next poll question.
And before we do, though, Jennifer, don't you? I think it's that the 50% data on this earlier slide was really important, and it's very important for providers that have projects that are in the works, either under development or on paper or with an LOI, to make sure that your advisors like Cheryl and you, Jennifer, and me know these things and have good examples, because we need those examples to sell in Washington and in Baltimore to help make our case.
Absolutely. Absolutely. And that's exactly what needs to be done. Stakeholders need to go and make their case. A lot of members, senators, House members, folks in the administration that supported this change don't fully understand the impact that it's going to have. And it really was as simple as we need to pay for that the president and the Congress can get enough votes to pass. And this one looks good, so we're going to put it in this broader package. There wasn't a lot of consideration. There weren't hearings, et cetera, like there should be, which, again, I'll just underscore, really creates opportunity, because going before lawmakers and regulators and saying this is what's going to happen and these are some changes I think need to be made to help patients will have a significant impact, and it can make a big difference.
One of our hospital associations has just put out a survey to all the members to solicit these stories, but the more of them, the better. In fact, a deluge is better than a trickle for sure.
Yeah, and there was very little information like this in front of lawmakers in the final months. And I realize this did come as a bit of a surprise to a lot of stakeholders, and so it takes a little time to assemble. But I think, we really need to hit the ground running immediately, because things are going to start moving pretty quickly in the next couple of months.
I agree with you, Jen. So I cut you off right before we were going to go to the next question, I think. Or did you have some comment on that?
I'm just really interested in the inpatient rules, the proposed rules when they come out, and see what CMS is going to say about this in April.
Yeah, I think they're going to trickle stuff in. In fact, on Tuesday, I think they implied that they were going to punt their interpretations of this off to June or July.
Maybe the outpatient rule.
I think they're going to punt it to the outpatient rule in June or July. So we now have another, several months of uncertainty. And my read of Dave's commentary during the open door was that they ain't going to give us any guidance between now and then. They gave us one FAQ on the modifiers, but big whoop, that doesn't help us figure out how to answer some of the challenging questions that are coming in through your Q&A window right now. But if we have to wait another 5 months before we get any guidance on this, that's a lot of wasted planning time, or worse, if providers go ahead with a transaction that turns out to have the rug pulled out from under them. That's the worst of all worlds. So what do you want to do our next polling question, Emily?
Yeah, so our final polling question is, For those that have provider-based clinics, did your facility convert billing to the Medicare OPPS system, or do you continue to bill all clinical services on the CMS 1500 form and obtain payment under the physician RVRBS system? And your options are split bill facility service on the UB04, physician service on the CMS 1500, or bill 100% of the clinic service on the CMS 1500, don't know, or not applicable. And as a reminder, once you have completed all CPE requirements, you'll be able to download a PDF of your CPE certificate from the certification icon at the bottom of your screen. I'll let everyone have a few more seconds. And let's take a look at our final polling results.
This is Cheryl, and I'd like to speak to this. This question is something that's come up over the years, and I know Larry and I have discussed provider-based clinics and whether they've complied with all the provider-based regulations, but we have had a couple clients that have converted to provider-based in the past, but they never converted their billing to the CMS split billing to the UB04 and the CMS 1500. They continued to bill everything on the CMS 1500. So I'm concerned about the grandfathering provisions of hospitals that might not have done the split billing. So we're really going to need to know what gets grandfathered and what doesn't. Do you have any comments, Larry?
You know, I think we do need to wait, but if I was a betting man, I would say that those providers who were not split billing at all prior to November 2, 2015 are SOL. I think they're not going to be grandfathered. That's what I'm concerned about. Yeah, I'm concerned about that.
So 46% of you say you're doing the split billing. 5% of you are saying that you still bill 100% on the CMS 1500. 23% are don't know, and almost 25% is not applicable. And I think
Purple guys better go find out. Purple guys better go find out, because that's going to tell you whether you've got grandfathering or not.
Should we turn it over to the Q&A? It looks like we've got a few questions.
We've got a slew of great questions, Cheryl. Let's get them.
All right.
All right. Our first question is, for billing purposes, can we still be on a UB04 form, or are we supposed to bill on a 1500 form? In other words, this is a reimbursement change, but what are the rules about how do we bill for these services after January 1st, 2017?
I'll go first, but
okay.
At this point, we're still waiting to find out how CMS wants hospitals to bill. And I know, Larry, you and I have debated this, but we believe that these off-campus non-grandfathered facilities are going to be having to bill on the 1500. We would not expect a UB claim form to be dropped for the facility component of the service.
With respect to the grandfathered ones, I think the answer is going to be that everything stays the same. For the new ones, though, right, I think it's going to be real hard for a lot of hospitals to be able to put out a 1500. They might not have the systems in place to do that. I'm also curious about what that's going to mean for services that might not have a payment differential. So I think that if this is an area where you have a hospital that won't be able to crank out a 1500 and you need to use a UB, that's a great piece of feedback to give to CMS. CMS is taking comments on their proposed rule at provider-based departments at cms.hhs.gov. And if that one is critical to you, I would say spit that question at them.
I agree.
Thanks, Larry. Our next question is, does the ban on new provider-based off-campus sites apply to a new under arrangements off-campus joint venture?
I'm going to punt to
Larry.
Larry.
Take that one, Cheryl?
Yeah,
depends on what kind of under arrangements deal you've got. If it's an under arrangements deal that has created a new provider-based department, then I think the answer is yeah. unless you're grandfathered or a DED or within 250 yards of a remote location or the main campus. It's new, and therefore the ban applies. Now, if it's a off-campus under arrangements diagnostic service, which doesn't have to be in provider-based space at all, such that the billing would potentially be at a location that's not sort of site-specific, that one might well be an opportunity to continue doing that. Or not to continue doing that, to say that it wouldn't be subject to the ban. I think that's a good question. I think the answers may be different for diagnostic and therapeutic services for under arrangement purposes. Feel free to disagree, Cheryl, if you do.
No, I'm there. One of our slides, we did talk about joint ventures and off-campus, not necessarily being subject to provider-based rules. Those would be freestanding.
Yep.
Right. Yep. So that's why I'm,
under arrangements. Yeah, go ahead. Under arrangements.
Different.
It might be different. Might be different if it's for diagnostic services.
Okay.
Again, a great question for CMS to respond to, because diagnostic under arrangement services don't need to be in a provider-based space. That's
okay.
The short answer for why I'm thinking that. Emily, which one do you want to do next? Or do you want us to pick them out?
I can just go down the list here. We've got quite a few questions, and just as a reminder,
sure.
If we don't get to your question today, we're happy to follow up with you after the webcast.
Sure, shoot.
So it looks like the next one here is establishing an ASC a viable strategy to continue providing OPD services?
Cheryl, you want to field that one?
I'm thinking about this one. So an ASC, so what CMS is saying about site neutral payments, they would default to either the, say the physician fee schedule or maybe the ASC fee schedule. And I'm not sure about providing outpatient department services. I'm going to have to say I'm not sure about that one.
Well, I think that here's my take on it. If you really want to provide surgical services there, setting it up as an ASC you might as well, because why bother with living up to hospital licensure, certification, supervision, maybe rules, if you're only going to get paid at the ASC rate anyway. So my thinking is, if you've got a new site and you can't be grandfathered and you want to do surgical services, you're not going to become an OR, so why the heck not turn yourself into an ASC? Makes sense to me.
That makes sense. I want to add, I think I see a question further down. We just want to note that critical access hospitals that are already billing provider-based clinics on the UB04 claim form are not subject to Section 603. Section 603 is specifically applicable to hospitals that get paid under OPPS, meaning the APC fee schedule amounts, and critical access hospitals are cost reimbursed. So at this time, this has not been expanded to critical access facilities. So next, Emily.
All right. Can you add new physicians to a provider-based clinic? Can you expand space in an existing provider-based clinic? And what happens if your provider-based clinic moves?
Yes, you can always add physicians to a provider-based clinic. This is not a provision that is preventing you from adding, changing, deleting physicians. This Section 603 is specifically related to services, new services in an off-campus department.
I agree.
As far as, expanding space in a provider-based clinic, I'm not sure. I would think that CMS would allow you to expand space, but you can't change addresses.
This is one of those. I think this is one of those areas that have caused a great deal of concern. Expanding space, moving provider-based departments, and changing or adding services is one of the things that my clients have been the most concerned about with regard to grandfathered facilities, on the fear that if they do that before the rules come out, someone could come along and say, that's not grandfathered anymore because the department that was grandfathered looked like it looked on November 2nd, and then it changed. So we've got a number of comments into CMS that that would be a terrible interpretation of the statute, and it would require hospitals to keep outmoded, inefficient, not community designed, community need designed facilities in place simply to preserve OPPS billing. That would be a terrible interpretation, but it's a plausible one that therefore we're worried about.
Yes, so as Larry said, we will have until July maybe or August to even find out what CMS is thinking. Okay.
Yep.
Emily,
all right.
Do we have time for one more?
Yep, I believe we do. Our next question is, will a surgery center that is off campus that has been paid under provider-based rules see a 38% reduction in reimbursement effective January 1st, 2017? I believe hospital-based surgery centers have enjoyed that level of preferential reimbursement.
No.
Well, this goes... No?
No.
I agree. There's no reduction.
Right. If it's grandfathered, you're safe. And if it's not, you're not.
All right. We probably have time for one more if you guys are up to it.
Sure.
All right. The language of the regulation indicates that non-qualified providers can't get reimbursed as HOPD. It doesn't say that they can't bill it as HOPD. Is there a chance that Medicare will come up with a way to pay providers differently?
All right, I'll start. Larry, I know we both have some comments on this. We're saying when you say non-qualified providers, we're assuming you mean the non-grandfathered HOPD clinics. Yes, you can. So if you're non-grandfathered, you cannot get reimbursed the APC payment plus the physician portion, which tends to be more than the straight physician fee schedule amount. What we are thinking is that if you can't get paid the APC plus the physician payment and payment defaults, theoretically, let's say payment defaults to the physician fee schedule amount, then it would be easiest for CMS to require the facilities to bill on the 1500 claim form. And as Larry said, not all hospitals are set up to do 1500 billing. So that's why we are thinking CMS is going to default to the 1500 because it's easier for them, and we're assuming they're going to have the hospitals do the IT programming on their systems.
I think that's probably the best reading of it as well, but it would also be probably convenient if hospitals had the opportunity to continue billing on a UB and let CMS just default down to the freestanding rate. That would be convenient. We'll see what happens. In fact, that was almost the way CMS most recently introduced the statute, talking about different rates. I'm also curious about whether the department would have to then meet all the separate rules, whether they're supervision rules or organizational rules of the freestanding setting. So, for example, we were talking a minute ago about ASCs. Obviously, ASCs have all different rules, conditions of coverage and the like, than the hospitals and their COPs. I think a really interesting open question is going to be, does CMS really want hospitals to run around and change all those things for new sites or sites that somehow aren't grandfathered anymore? Jury's out, Cheryl. Don't you agree? Till we get at least a hint in the proposed rule this spring and summer.
You bet.
I know that Emily's about to give us the hook, but there are a lot of other good questions that were showing up on our Q&A window, and so we should probably try to field a few of them offline if anyone needs to reach out to us. Our contact information is on the slides.
Agree.
All right. Well, thank you, Larry, Cheryl, and Jennifer, for an awesome presentation today. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet in order to receive credit. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE icon at the bottom of your screen. Open the icon and click the printer in the lower right corner to download a PDF copy of your certificate. I'll keep the webcast console open for a few minutes to give you time to download your certificate now. A copy will be emailed within 2 weeks should you have any difficulty today. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey as your feedback is very important to us. Thank you again for joining. Good morning and welcome to today's webcast. What do site-neutral payments mean to your off-campus facility? We have three great speakers joining us for today's presentation: Larry Vernaglia and Jennifer Walsh of Foley and Lardner, and Cheryl Storey of Moss Adams. Larry is a partner and healthcare lawyer with Foley and Lardner and serves as chair of the firm's healthcare industry team, named Health Law Firm of the Year for 3 of the past 4 years on the U.S. News Best Lawyers, Best Law Firms list. Mr. Vernaglia represents hospitals, health systems, and academic medical centers, and a variety of other healthcare providers. Jennifer is a public affairs director with Foley and Lardner. She has extensive experience in government affairs, including a lengthy career as a senior staffer in the U.S. Congress and the California Legislature, and as a vice president for federal government affairs at a top 20 Fortune 500 healthcare company.
Moss Adams is pleased to present another in our ongoing series of continuing professional education webcasts. Our presentation will start in a few moments.
She is a member of the firm's government and public policy practice.
Here are a few things to keep in mind.
Cheryl has built her experience in the healthcare field for over 30 years.
You can customize how you both view our presentation and interact with the presenter.
Medicare and Medicaid reimbursement
For better viewing,
and related billing
close all other applications and turn up your speaker volume.
Cheryl has worked with healthcare providers
you
on
can also
graduate
adjust
medical
window size
education
and placement.
programs, compliance with CMS's
At the bottom of your screen,
provider-based
you'll see a series of icons, each relating to a different aspect of our session.
And certification and
For example,
of the
you can click the File folder icon to download the group attendance sheet and a PDF copy of today's slides. You can ask our presenter questions during the webcast by clicking Q&A in the bottom left-hand portion of the icon bar and typing in your question.
In particular,
we'll do our best to answer all questions during the presentation or follow up via email.
And Jennifer, on this important topic, what does site-neutral payments
We'll ask polling questions
mean to you?
Throughout today's presentation.
And what we have
Per the
today
National
is
Association
one
of State
of a
Boards of
series of
Accountancy
interesting
webcast
issues that are
CPE
going on
standards.
for hospitals and their
CPE
outpatient
credit will be
departments
awarded based on your
just over the past
participation
9
in these
months.
polls.
If you think
To
about
respond
it,
to a poll,
just
click
since
the button next to
spring,
your answer.
we've had a dramatic
If you're attending this webcast
level
in a
of
group,
increased attention
you
to
must
the
complete our
so-called
attendance
shared
sheet to receive
space
CPE
prohibition
credit.
for provider-based
Please have all group members sign the sheet,
for hospitals.
and please remit only
We've
one
seen new
sheet per
stark
group.
exceptions that implicate
Also note,
these
today's
facilities,
session will
such
offer
as
you
the
one
new timeshare
CPE
exception.
credit. To
And we
receive
have
credit,
today's
you must
topic,
meet the
which is
requirements
the
as
impact
specified by
of
the
the
National Association of State Boards of
Bipartisan
Accountancy.
Budget
You must
Act of
attend at least 50
2015, Section
minutes of the session
603,
and respond
which
to
is
at
going
least
to be our
75%
topic
of the polling
du
questions.
jour. And we hope that over the next hour or so, we'll be able to cover the legal issues, the public policy, as well as the finance and operations issues that arise from this short, but in our view, very dramatic and far-reaching statute. So let me jump right in to make sure that we're all on the same page about what the Congress did at the end of last year. And here's the short of it, that as of January 1st, 2017,
to apply this content to your specific
an off-campus outpatient department of a provider can't bill under the outpatient prospective payment system for Medicare unless either it's grandfathered or it qualifies as a dedicated emergency department, an EMTALA term we'll spend some time on in a moment. After this date, unless you're grandfathered, and you don't meet the DED carve-out, you're going to need to find another way to bill other than OPPS. And we're not exactly sure what they will be, likely the Medicare physician fee schedule, but maybe some others such as ambulatory surgery centers or rehab centers. There may be others as well, and we're going to have to wait for what CMS chooses to do to figure that out. But this site neutrality, at least for new facilities, is exactly what MedPAC, the Office of the Inspector General, a number of payers have wanted for years. In fact, many people said it didn't go far enough because it's allowing for grandfathering, which we're going to talk about in a moment. This law was only passed in December, so what we have is a statute only a couple of pages long. There is no regulation or really any other meaningful guidance. People like Cheryl and Jen and I have been trying to read tea leaves to figure out what the impact is going to be on new facilities as well as potentially some existing facilities. And we are doing our best, but right now we're going to have no guidance from CMS, at least until June or July when the outpatient prospective payment system rule comes out, where we believe that they will issue their first interpretations and guidance. So let's talk a little about why this Section 603 was passed. Well, it's purely a revenue play on behalf of Congress. It was designed, that plus the extension of sequestration payments were designed to lift the debt ceiling, increase some domestic spendings, and avoid increasing Medicare Part B premiums. How much is going to be saved? Well, the CBO scored this at around $9.3 billion over 10 years. And that's the savings they were hoping to achieve. There was a flurry of activity at the end of the year with hopes of making some modifications to the statute. And right now, while there may be some additional legislation coming that we'll let Jennifer talk about towards the end of our time together, this is the law as it stands today. Note that CMS states that, or says that, Section 603 is not effective until January 1, 2017, and that it won't change anything until then, and I think that's true. But the grandfathering provisions we'll speak about do look back in time to before the passage of the statute, and it is conceivable that actions that providers take in the coming year could impact the compliance and grandfathered status of their existing facilities. So with that background, Emily, let's launch into some of our first polling question before we start digging in. Emily?
All right. So our first polling question is, are you from a hospital or health system, a physician office, other clinical practice, or non-clinical? I'll give everyone a few moments to respond. To participate in the polls, just click the Submit button after you select an answer. And I'll give you all a few more moments. And we'll take a look at the results. Larry, back to you.
All right.
Cheryl, those numbers don't surprise me too much because this is an issue that's dramatically important to hospitals, particularly as they try to sort out what some of these terms in this little thin statute mean. One of the most critical of these is in the definitions. Do you want to walk us through some of the definitions, particularly the on-campus one?
Sure, Larry. So what we're going to do is go through, first of all, what's on campus. And it's going to be your buildings or structures within 250 yards from the main building. And there's been a lot of question as to what 250 yards means. And we're finding that not all the states are consistent. So we're hoping CMS will improve the consistency in the way states evaluate the 250 yards. But we do have some definitions from some states that if it's more than 250 yards, it's still considered on campus if you have a connected sky bridge or something to connect the one building to the other. Before we received this, we once had one of the states tell us that it had to be 250 yards from the ED entrance, which would really impact the number of buildings considered on campus. So it's kind of a question as to how many people are going to start building sky bridges. So it's really important to check with your particular state. And another thing to consider is not every state licenses ambulatory care facilities as part of the hospital. I know that Idaho and Montana don't necessarily license or survey those types of facilities. So then next, what is off campus?